So welcome everyone. Good afternoon. Welcome to the HPL seminar. Today it gives me great pleasure to introduce Dr. Karen Troy. So Dr. Troy is currently a professor at Worcester Polytechnic Institute, or Worcester Polytechnic Institute in WPI as they call it, in the Department of Biomedical Engineering. And before moving to WPI, Karen was at the University of Illinois at Chicago. And Karen was actually my postdoctoral supervisor for 4 years at UIC, which were some of the most formidable and productive periods of my career for sure. Dr. Troy completed her bachelor's degree in biomedical engineering at Washington University in St. Louis. Actually, she wasn't done with that. She also did another degree in systems science and mathematics at Washington University. She then went on to obtain her PhD in biomedical engineering at the University of Illinois under the supervision of Tom Brown. And if you don't know who Tom Brown is, then your PI has failed to educate you on the most seminal computational biomechanics literature. Dr. Troy's research is focused on understanding why and when a mechanical load is beneficial versus damaging, and how to manipulate mechanical loading environments to optimize bone structure and strength. She has a number of scientific accomplishments, but she is most proud of her work in spinal cord injury and bone loss and translating that work into clinical practice. In her free time, Karen likes to play outside. During the summer of 2020, when COVID first hit, she did a solo hike of what's called the Long Trail in Vermont. So this is the oldest distance trail in the United States. And it's about 273 miles long, or 440 kilometers long. She also enjoys baking. She's had a sourdough culture named Carl, who's lived with her for over 20 years. And she likes growing things in her garden. So as a reminder, I'll first turn it over to Dr. Troy for her presentation, and then we will have a question and answer period. And at that time, I'll remind everyone how to submit questions. So Karen, welcome, and feel free to begin.
All right. Thank you all so much for the invitation, and thanks, Brent, for the nice introduction. What I'm going to try and do here is share my screen. Give me a second. Oh, wait a minute. I have order of operations issues here. All right. I think we're just going to make this inelegant. Give me a sec. I gotta fix one thing. There we go. All right. Can you all see my slides?
Yeah, it looks great. Excellent.
Okay, cool. So what I thought we'd do today is talk a little bit about imaging and models and clinical questions about skeletal health. As Brent mentioned, I'm from WPI, Worcester Polytech. I thought I'd just show you where that is on a map. I did find a map that didn't cut off the word Alberta. That was hard, by the way. But we're way over here. We're a small private technical university. So this is kind of what our campus looks like, and which is in the winter, which is about half our year. So we sort of sit in a different space. We have about 4,000 students, and we really balance teaching and research pretty equally. This is my lab. We have a lot of fun. We like to go hiking. This is not actually climbing. This was the sideways camera trick. So we were just having a good time. So you'll see work done by a couple of these students as I go through. But my lab really focuses on the interaction between physical activity and musculoskeletal health. And we're interested in looking at interactions between bone and joint loading, and then understanding how when people load their bones and the joints, that translates into mechanical behavior, and how that mechanical load can either lead to healthy adaptation or disuse injury or overuse injury, and sort of what distinguishes the loads that cause each of these types of responses. So I always like to start with my why. And one of the questions that I'm very practical when I think about what I do. So I want to know, like, what should I tell my mother, right? So here's my mother. She's an older woman. She's got some biological risk factors for bone fragility. She's including, she had breast cancer, she had chemotherapy, she had aromatase inhibitors, which disrupt bone metabolism. But on the good side, she's a runner. And so she's a person who's interested in using physical activity to try and keep herself healthy. And so my goal for someone like my mother would be to preserve bone strength and avoid injury. And unfortunately, this is my mother's hip as of 2019, which is not what you want to see your phone call coming through looking like. They put her back together. So this is what she looked like a few months later. And I'm happy to report that she's back up to running about 25 miles a week again. So there's the good scenario, but it would have been great if this hadn't happened in the first place. And we know that this happens to older adults and specifically to older women. If we look at fracture rates, you can see that the rates go up quite a lot once people get older. And there's two reasons for this. One is because, of course, people have a higher incidence of falling as they become older. And the second thing has to do with bone mass. And so we know that during our growth and adolescence, we're gaining a lot of bone mass. During most of our adult life, we sit there at our peak bone mass. And then, especially for women around menopause, there's a very steep decline in bone structure. And then you continue to lose bone mass throughout our aging. And so these are the sorts of factors that we need to think about preventing. So I'm an engineer and I like to think about mechanics a little bit. So ultimately, when I think about what makes a bone strong, I'm thinking about the structure of the bone, its shape, its size, how thick the cortex is. I'm thinking about the microstructure. So how does the trabecular bone look? Here's a strong trabecular microstructure versus a weaker one. And then I can also think about the material itself and how it's behaving. And ultimately, in my lab, at least for present purposes, we define bone strength as how much force or torque does it take to produce a fracture. So we know that physical activity matters in these realms. And this is a really cool study that Mariana Kirsch shared with me, looking at changes in humerus architecture in throwing athletes. So these are actually Major League Baseball pitchers. You can see the throwing humerus cross-section here, the non-throwing arm here. And it's pretty obvious that there's quite a difference. And that difference is coming from the forces and the torques that happen during a baseball pitch. And what's really cool is that if you take a comparison of this and you look even 50 years after players retire, you can still see that there are some differences in the shape, although they start to become much more similar. And so what we see is if you look at just the diameter of the throwing arm versus the diameter of the non-throwing arm, then you can see that there are really these lifelong changes that happen really in the size of the bone itself. And so we know that some bone adaptation, especially when you do it when you're young, that's a lifelong change. And for those of you who are engineers in the audience, if we know that the inertia, so the sort of the resistance to bending of this shape is proportional to this radius to the fourth power. So it really makes a huge difference having a big increase in bone like this. So this causes me to say, maybe I shouldn't really be thinking about what I should tell my mother. Instead, I should be thinking about what I should tell my daughter. And I apologize, I know video doesn't always work so great in Zoom, but here's my daughter. So she's 13 right now. She's actually taller than me. I was just telling Brent. And so she's got some family risk factors, but she's also a person who does a lot of mechanical loading. So right now she's a gymnast. She spends a lot of time pounding on her bones. And so I want to think about how could I help a person who's younger maximize peak bone mass and reduce their lifetime risk of fractures through mechanical loading. So conceptually, we use a model of functional adaptation of bone structure where we think about mechanical stimulus being on the x-axis and then bone formation or resorption response being on the y-axis. And during most of our adult life, our bone is in equilibrium. And so even though we have bone turnover, there's no net change in that bone. And so we have this equilibrium status. As you add a novel mechanical load, your bone can be pushed into this hypertrophy zone where you have more formation than you do resorption. On the other side, if you take away that mechanical load, then you're going to get an atrophy response where you now have more resorption than formation. And so ultimately, there are lots of mechanisms that this mechanical stimulus actually triggers, including osteocyte deformation and fluid flow and a bunch of others. For my purposes, since I'm interested in people, I'm generally thinking about these as being related to mechanical strain because that's something that I can measure or either directly or indirectly. And so in the work that you'll see here, we use mechanical strain as a surrogate measure for looking at this mechanical stimulus to the bone. So just some clinical evidence about that. So here's an example of atrophy. So here's some work done looking at bone around the knee after spinal cord injury. And you can see here, once you become acutely spinal cord injured, you go from walking around like a regular person to suddenly being non-weight bearing for a prolonged period of time. And you can see that after about 3 years, 36 months, you've lost about 50% of the bone around your knee. So that's a very acute atrophy response. On the flip side, we have a hypertrophy response. And so this again is another gymnast example, really from the early 2000s, but they followed gymnasts longitudinally over a 2-year period. And so these black bars represent the competitive gymnastics season. And then the spaces in between show us the time off in between the competitive season. And what you can see on the y-axis is lumbar spine bone mineral density. And you see that it increases during the competitive season, and then it actually decreases during the off season and then increases again. So this is a really good example of how we can observe hypertrophy in humans. And so the question that I always wonder is, what if we could design an exercise to be osteogenic? And so what I've put up here is a number of different equations that many individuals have proposed to try and predict how much bone you would gain due to a particular mechanical stimulus. And so what you can see with all of these equations is that they have several things in common. They have components denoting magnitude. They have some kind of a frequency or a rate or an acceleration. Many of them have the concept of the law of diminishing returns incorporated as an exponent or as a log. And the problem is that all of these equations are either retrospective. So this BPAQ is an example of a retrospective equation, which is a survey metric, or they don't account for individual differences in bone structure, or they're kind of nebulous, and none of them have been validated prospectively. And so again, going back to my question, what do I tell my mother, right? Which of these relationships do I use? I don't know if they're valid in people. I don't know what strain to use or what frequency to use or which acceleration to use. So these are all really cool theories, but I'm a little bit more interested in how I can actually operationalize them. So today I'm going to talk about some of the non-invasive methods that we have validated in my lab to assess bone strength. And then I will show you how we model them, and then we'll do a couple of different case studies to look at examples here. So the first thing we need is a non-invasive method to estimate bone structure and strength. And like many others, we developed quantitative computed tomography or QCT analysis methods. And this is an example here that's showing, so this is distal forearm. So this is your radius, right? Your thumb would be over here. Here's your ulna. This is the first carpal row here. And so in a CT image, all we have to do then is we need to know the size and the dimensions of each of the 3-dimensional pixels, which we call a voxel. And then we can note that the X-ray attenuation value, which shows up as the gray value, is linearly proportional to the amount of mineral present at a given location. And so by identifying regions of interest, we can add up the pixels and then we can calculate different parameters, such as bone volume or density or mass. And then we can even make different engineering calculations, second moment of area, section modulus, and some other things to try and estimate strength of the different structures. So the next question we have to ask is, what are the loads that we're actually interested in? And that really depends on what the question is that you are asking. So we might be interested in physiologic loads, for example, in our baseball player. We might be interested in a fracture scenario, so we might want to simulate a fall. Or we might be interested in simulating a simple type of a load for a virtual mechanical test. So we could take a bone and load it in tension or compression or torsion or bending. So then ultimately we take all of this data and we're going to use it to create a subject-specific finite element model based on our CT data. So we need to have the model geometry and the material properties, and we get that from our quantitative CT images. So here's our geometry. Again, here's our forearm as an example. And what finite element modeling fundamentally does is it takes a very complex structure like a bone, and you can discretize it into thousands of very simple structures like this tetrahedron here. And then you can put them all together and assign them material properties and define how they're connected to each other, and then use them to solve basically many thousands of simpler math problems rather than this very complicated structure. And so we basically get the geometry from the image, and then we assign material properties based on the density that we get from the images. And here's an example of a number of density versus modulus relationships, which were defined using mechanical testing from cadaveric bones. So the next thing we need to do, see, Brent can't, he's stuck in our images here because he helped with some of this work, which is that we need to estimate tissue level mechanical strain, and we need to validate our models. And to do this, again, I'll show you a distal radius example, since that's a lot of the area that we have looked at. So here's a cadaveric specimen. I apologize for any gross pictures. We put a series of strain gauges around the bone in the region of interest. And then in this case here, we image the region of interest. So here's our CT image of our radius. And in this model, we were actually interested in looking at microstructure. So we also got high resolution CT of our radius. We take this, we make models. So in this case, we're actually inserting the high resolution model into this larger model so that we could understand something about how the microstructure is loaded physiologically. And then we can apply our boundary conditions to the model. So in this case, we're simulating pushing on the palm of the hand. And so we have to measure we have to put the articular contact into this model, and then we can understand what's happening inside the bone. Now, ultimately, to validate the model, you need to have a comparison with some sort of measured reality. And so in this case, we're comparing our measured strains with our strain gauges versus our predicted strains that we measure, that we get with our models. And you can see in most cases, our models come out pretty good. We can typically estimate somewhere between, I would say, 86 to 90-ish% of the variance in strain. Okay, so let me show you a couple examples of how we've used this. So the first one that we did was really trying to get at this conceptual model of mechanical stimulus versus bone adaptation. And we asked the question, how do strain magnitude and strain rate, which are two key aspects of mechanical stimuli, affect bone adaptation in healthy adults? So this was a randomized prospective clinical trial. We enrolled 102 healthy adult women. They were all at peak bone mass, and they should be at the age where they do not experience any age-related changes due to their bone mass. They were given an intervention, which is 12 months of mechanical loading to the distal radius by leaning onto the palm of their hand, 100 cycles per day, 3 to 5 days per week. And we had 5 different groups. So we had the high and low strain magnitude group, and we had a high and low strain rate group, and a control group. And I'll just point out, these 4 individuals, Megan, Joshua, Tiffany, and Saba, were really critical to getting this clinical trial done, although many other people were also involved. So one of the things that was unique about this study is that rather than assigning a force, which is how a typical exercise clinical trial would occur, we assigned a strain. And we could do that because we had knowledge of each individual person's anatomy. So what we did was we had a target strain for their group. We took a CT image and we created a subject-specific model of their anatomy. And based on that model, we created a force versus strain relationship. And we used that to assign them a target force that would produce their target strain. And we programmed that into a loading device. And the loading device consisted of a load cell and a couple of LED lights that would light up and a data logger. And so every day that they did their intervention, the data logger would record their actual achieved force. And so we could periodically take the data off of the logger, plug it back into this FE model in order to figure out what strain they actually achieved. And in this case, our outcomes were to look at quantitative CT measures of bone mineral content was the primary outcome. And then we had secondary outcomes of microstructure. So the first analysis compared groups considering the assigned rather than the achieved loading. So this is an intention to treat model. And what we found is that while the control group saw decreases in integral bone content, so integral means everything inside the periosteal surface, that's all the bone. You can see the control group has decreases. The low magnitude and the low and high strain rate groups saw significant increases relative to the controls. And additionally, the strain rate groups had significant increases in endocortical bone mineral content, that's this middle bar, and compressive strength index, which is one of these calculated engineering metrics. And so the lack of significant differences that we found in the high magnitude group did not support our hypothesis that high strain magnitudes were associated with bone formation. So at this point, the majority of bone clinical exercise trials stop. And you're kind of left scratching your head wondering, why didn't we see a group difference that we expected? So now this really highlights the value of measuring what actually happened and understanding, because now we can look to see what participants are actually doing. So here we can see that while strain magnitude was higher for the high versus low magnitude group, that's these lines here, and strain rate was higher for the high versus low rate groups, you can see that there's variability in the number of loading sessions that each person completed. And ultimately, the mechanical loading ended up being confounded by participant compliance. And so we decided to move to a second analysis. So now we looked at strain loading dose as a metric of actual achieved loading and its relationship to change in bone mineral content. And so the loading device recordings were analyzed using a MATLAB script. So you can see this is actual recordings. So we grabbed all of the peak here and we calculated loading dose as the product of strain magnitude, rate, and the number of loading sessions performed over 12 months. And then loading dose was set to 0 for the control group because they didn't do anything. So now when we look at this plot here, we can see there was a significant and positive relationship between loading dose and percent change in integral bone mineral content. But there was a lot of scatter. It only explained about 10% of the variability. So we did one more analysis here, and now we compared achieved loading characteristics based on who gained or lost bone. So the first thing we did was we took all the participants and we ranked them based on the measured change in bone mineral content. And then we divided them into 3 equal groups or tertiles. So by design here, we see that the top tertile has gained the most bone, the middle tertile didn't really change, and the bottom tertile actually lost bone. And one of the things that we did is we compared demographic characteristics between these groups to make sure that there was nothing about the participants themselves that was different. But they were similar in age, they were similar in height, weight, everything that we could look at about the person was not different. So when we compared, the only thing that was different actually was the achieved loading parameters. So that's what we show over here. You can see that the top tertile had significantly greater strain magnitude, strain rate, and strain loading dose than the bottom tertile. And this supports the hypothesis that high strain dose is associated with a bone formation response. So we took a little bit of a deeper dive here to try and understand what was actually happening inside the bone microstructure and whether local strains were associated with local formation or resorption. And so for this study, we included just a subset of control and loading subjects who had good quality scans at 0 and 12 months. And of course, the control subjects did not participate in an intervention. So we hypothesized that we wouldn't see a relationship between strain and adaptation in the control group, but we might in the loading group. So to do this, we took differences. I'm happy to go into the technical details later to identify sites of local formation and resorption. And then we overlaid that with our strain here. So for each formation and resorption site, we calculated the local stimulus, which was the mean strain magnitude or gradient within a 200 micron circle of that location. So this accounts for the fact that adaptation is a response to biochemical signals from neighboring osteocytes. And then we calculated the overall median strain values across formation sites and across resorption sites. So in this plot here on the right, we've plotted the percent difference in median strain between formation and resorption for the loading and the control groups. And what you can see here is that the numbers are all positive, okay? So what we see is that the median strain magnitude and gradient are about 6 to 8% higher near formation sites compared to resorption sites. So that's significant. So next we asked whether low strains were more likely to be near resorption sites and are high strains more likely to be near formation sites. So to do this, we thresholded strain magnitude and strain gradient to identify the 5th and the 95th percentiles. So we just grabbed the very lowest and the very highest strains. And that's what you see in the blue is the very lowest and the red is the very highest strains. And then we determined the number of low and high strains with formation or resorption element that's in close proximity. Okay, so basically we're looking to see how many blues are near resorption and formation sites. So ultimately, yeah, I was going to say here. So we've got percent of low strain near resorption, the percent of high strain near formation, and the percent of high strain near resorption sites. Got that? I know this gets confusing. All right, so here's the take-home message. So we see that for both strain magnitude and gradient, low strain elements, so this now we're talking about the blue zone here. Okay, so low strain elements were more common near resorption, which is aligned with our overall hypothesis that bone is removed from low strain regions. But we did, and you can see that because if you look here, you can see that the purple is greater than the green in both, right? But in the high strain, we didn't see that trend. Okay. So just to kind of summarize, what we found when we looked at the microstructure is that low strain regions were more common near resorption sites than formation sites. We found that formation and resorption were more likely near high strain versus low strain sites. This relationship between resorption and strain was less clear, suggesting that low strains may drive resorption of unnecessary or unloaded bone, while overstrained regions, as well as overstrained regions with microdamage. So while we observed significant relationships between strain and adaptation, about half of the adaptation behavior was not driven by strain, and we only saw about 10% higher median strains near formation than resorption. And what was a little bit surprising is that we saw similar trends for both the loaded and the control groups, and even though the control groups didn't do anything. So we think this is because our axial boundary conditions that we applied to our model probably generate strain distributions that are similar to activities of daily living. And so even though they're less intense than the loading intervention that we gave them, we think probably the same regions that experienced high or low strain during activities of daily living were simulated in our model. So it's important. So we interpret this finding such that bone under a normal loading or with new high intensity intervention, strain is still influencing where the bone is added and removed. So overall, this suggests that local strains influence local adaptation, and we could eventually use this to design interventions that could target specific vulnerable regions within bone. Okay, so let's move on and talk a little bit about spinal cord injury. One of the questions that we started to ask when Brent was still in the lab is whether you could use patient-specific finite element models and QCT as an outcome to evaluate osteoporosis treatment. And so some of the work that Brent did while he was a postdoc included validating some really nice models to try and basically do a virtual mechanical test on proximal tibias in torsional loading, which is a very relevant loading for individuals with spinal cord injury who get a lot of fractures around their knees. And we eventually used that as an outcome for this, for a couple of clinical trials, which I'll show you here. So the first one was a drug combined with mechanical vibration trial. And then Brent also ended up using this to understand how bone strength changed as a function of time since spinal cord injury. You remember I mentioned that bone loss occurs during that first 3 years. So after he left the lab, I started working with another clinical trial partner, Leslie Morse, and I had a grad student, Ying Feng, who was interested in doing some of this work. And so this particular clinical trial was looking at the effects of functional electrical stimulation assisted rowing in individuals with spinal cord injury. And then it was either with or without an anti-resorptive drug, zoledronic acid. That's what that ZA stands for. So you can see an example here of what FES rowing looks like. Basically, you put these electrode patches on your muscles, which you would typically be not able to voluntarily control. And then you can actually use an adaptive rowing machine, and you can trigger this e-stim unit with a thumb trigger to turn on the quadriceps and generate a rowing motion. And then there's another set of patches on the hamstrings that you can use to pull the leg back. So the biomechanics of the motion are actually fairly simple because the number of muscles surrounding the joint is quite limited. And because of that, we were able to instrument an adaptive rower and get some really nice estimations about the forces that were going through the legs and even through the bones. And then along with this, we used quantitative CT metrics as a primary outcome. So this is one of the nicer outcome measures we have. So this is now, again, using the same model type that Brian had developed previously. So we have torsional failure strength. And then now you can see it as plotted versus time after injury. And each of these little lines represents the longitudinal data for a single clinical trial participant. And it shows either their left or right limb over time, and then either with or without zoledronic acid. So ultimately, what we concluded from this work is that the rowing did not load the bone nearly as much as we had anticipated, although the drug actually ended up being quite effective. So ultimately, this work combined with a number of other studies is one of the things that I'm most proud with, because we were able to, for the first time, create some official guidelines on how to test and monitor bone health in people with spinal cord injury. And up until 2019, there really were no guidelines to help clinicians address this problem. So I thought I would end by talking about the clinical trial that we're currently finishing up. So this one, again, with Leslie Morse, now partnering with two of my master's students. Brianna Young is currently in my lab, and Nicole Matson graduated back in the spring of 2020. And amazingly, the internet does not contain a picture of her, which I think is quite an accomplishment at this point in her life. In any case, this was a clinical trial looking at the effect of exoskeleton-assisted walking therapy on people with spinal cord injury. And so one of the things that we started to think about after we finished the FES rowing study is FES rowing loaded bone quite a bit less than we had anticipated. Really, it was very difficult to get more than about a third to a half a body weight going through the legs. But even in an exoskeleton, even without using your muscles, you could potentially load it at least up to one body weight. And there may be other benefits as well. So this was a crossover study. It's enrolled 30 individuals. So basically, people were randomized to either immediate gait training or delayed gait training. And then they had standard therapy during the opposite 6-month period. So the fundamental question, which I don't have the answer to yet, is whether exoskeleton gait therapy is osteogenic. And then a secondary question that I'm interested in is to understand what is defining why is it osteogenic, right? Does it depend on loading dose? And the first step to doing that is to understand how people are loading their limbs when they walk in an exoskeleton. So to do that, we did video gait analysis. So we weren't, because this was all done in the clinic, there was not a gait lab that was practical to get people into. But what you can see here are videos that the physical therapists were able to take. And so using this, we could at least get sagittal plane motion, and each of the participants had force sensing insoles during some of their therapy sessions so that we could get plantar reaction force. So you can see an example. We actually had 2 different exoskeletons that we used in the clinical trial. The one on the left here, again, I hope the video is coming through. This is called the Indigo. And then the one on the right is called the Exo. This is actually the same individual who's walking in both, so you can compare and contrast. One of the key findings we found is that the Indigo had a faster walking speed. Individuals typically had longer stride length. And then there were larger ankle and knee ranges of motion that went along with those walking dynamics. Initially, we thought that that was also going to be associated with larger forces. And I think I'll show you the force data here. If you look, you can see that it's quite variable. So in this case, the red, this is knee forces, and this is coming from the inverse dynamics calculations. So this is knee force on as a percent body weight on the x-axis versus percent gait cycle on the y. This is knee moments. So you can see that the red and the indigo generally has higher averages, but it's not significant, mostly because of this big scatter. And I will say the scatter is coming from a number of different locations. The kinematics are actually quite consistent, but you noticed that everybody was using an assistive device. And so the degree to which they lean on that assistive device is going to affect the amount of force that goes through their foot. And so that's, I think, a large portion of where this scatter is coming from. Okay, so again, I'm interested in understanding this dose response. And so we proposed that we took what we learned from the distal radius study and thought about calculating some quick and dirty measure of loading dose. So just to remind you, in the distal radius study, we looked at the product of strain magnitude, strain rate, and the number of total sessions. And so as a first attempt, this is like hot off the press data, we've started playing with the number of discrete loading cycles, which we can get from the therapists. We need some sort of force metric, and we need some sort of bone strength metric. And then we could calculate dose as being, again, the product of all of those. You've got your steps and your loading rate. And then we just sort of said, okay, well, bone strain is going to be somehow proportional to the force divided by bone strength, right? If you have a larger force, you get larger strain. But if you have a stronger bone, you're going to get less strain. So again, this is just a quick calculation. We took our 3 typical strength metrics that we would calculate from quantitative CT. So we have compressive strength index, bending strength, and buckling ratio. And we tried it out. So this is our preliminary incomplete results at this point. And we just ran some correlations to see if there was any there. So this is showing us femoral epiphysis bending strength index loading dose as the loading dose. And then what you can see on I was looking here to see, oh no, okay. Sorry, this is, so this is epiphysis, metaphysis, and diaphysis. So 3 different loading doses depending on which strength index you use in which region. But in all cases, you can see that it looks as though there is going to be a relationship, although we still have some additional data to put in here. So we're really excited, and we're almost done with the data analysis, and we peeked at it this once as we were trying to make sure that we were going down the right path. So as I said, this is a first attempt. There's definitely other methods that we need to explore, but it's looking exciting. I think one of the things that I'm happy to discuss today is that I think response probably also depends on baseline characteristics of your individual. And I'm pretty sure that some people are bone gainers and some people are not. And ultimately, of course, the clinical goal would be to identify potential responders, predict the response, and then ultimately make a clinical impact in this population. So I'll wrap it up here. I think there's a lot of applications for models of bone, both clinical and mechanistic. We use almost all of these. I'm really interested in getting more into forward simulation so that we can try and predict things, but we need to know that our simulations are right and based in reality. And so that's the work that we're doing now. But right now, what we definitely are doing is using it as clinical outcomes. Anything that's targeting a bone, if we have a good model, then we can tell whether the bone has become stronger or changed its structure. And mechanistically, we're trying to get at this relationship between dose and response. And I didn't really talk about damage today, but one of the other really interesting questions, I think, is what makes a stimulus stop being good and start become damaging? And how do you figure out what's going to cause a mechanical load to create that tipping point? All right, so let me go back to my mother for a minute, because she's my reality check, right? So what do I tell her? I tell her to keep moving, right? So I think one of the biggest things is that we know forces are important. We know that physical activity is important, partly so it'll keep her from falling, partly because it's important for bone health. Obviously there's some common sense there, I think, as we age. One of the things that she stopped doing, we got these cool kick sleds. She used to have ice skates. Ice skates seemed a little bit too risky, but the kick sleds are super fun. So, common sense is good. What should I tell my daughter? I think I just tell her to keep moving and make sure that she's eating enough food and getting the right nutrients that she needs. One thing that came out of our wrist loading study, which I didn't present the data for today, is that a 1 standard deviation in bone mineral density equates to about a 20% increase in bone stiffness. So there's really quite a large effect of having these small changes, especially as you're maturing. And that's my daughter in the middle, just in case you didn't know. So I think the bigger issue, though, probably isn't people like my mom or my daughter. I think it's probably more sedentary individuals who really haven't gotten out and gotten that physical activity to get that peak bone mass that they need. Those are the ones who are going to be more in need of interventions later on. So with that, I'm just going to thank all of my current and past lab members. This is only a small subset, but every single person here was really critical to the work that you see now, or the person who is me, and helped fund it too. So with that, I am happy to call it a day and answer any questions. Thanks.
Thank you, Karen. I'm just gonna ask people to turn on their cameras for the Q&A session if you are comfortable doing so, and just let everyone know we do have a hard stop at 4 o'clock today because we are keeping Karen from her family tonight. So we'll be finishing up around 4 o'clock. Art, go ahead, please.
Hi, Karen. I have a question about your dose measure, and specifically about the role of loading rate or strain rate. And the reason I ask is that I have a colleague, his name is Brent Edwards, and he says that when it comes to fatigue, which is a different problem, that loading rate is commonly misattributed to be a contributor to fatigue, and he believes that loading magnitude is more important. Now, your study is about building bone as opposed to fatigue, but where my confusion comes in is that, in my mind, I sort of thought of them as being related to each other, is that you need to sort of do a little bit of damage in order to stimulate growth, or if you do too much, then that's bad. So I'm just wondering, what are you thinking in your dose measure when you include both a load and you multiply it by loading rate? So what's the story? And then is my colleague Brent wrong?
So I don't think he's wrong. Let me preface by saying, when we played with the dose measure, we actually we tried out some of those equations that I flashed up initially. They didn't actually work for at least the metrics, the way that we were able to implement them. We played with with loading rate alone, and we played with strain rate alone, and we also played with strain magnitude alone. And both of those did pretty okay, but when you combined them, it seemed to be better. So some of that was me diddling with the data, I will admit. What I have also tried to do since then actually is do sort of an exponential fit, where you basically, you could actually have it be strain magnitude to some exponent times strain rate to some exponent to, times number of loading cycles. And I think at this point, I wasn't able to get exponents that were significantly different than 1, but I think it's because I just don't have that much data. So I think the bigger question, though, has to do with biology. And my theory is that rate probably doesn't affect the material very much, but I think it is sensed by the osteocytes. And so you're going to get a bigger remodeling response due to higher loading rates, which can be good if you're trying to build bone, and can be good if you're trying to repair damage, and can be potentially problematic if you have so much bone suddenly being repaired that you're now causing other problems in the bone structure.
Okay. And so would you say that for both fatigue and for building bone, that strain rate does play a role biologically?
I believe that biologically it does, but I'm not sure that, I don't know how much it affects the material. I mean, bone is viscoelastic, so yes, there's a rate issue, but it depends on how variable it is. The other thing that I'll add on to that is I think rate is a lot easier to manipulate safely than magnitude. So as a person, like if I give somebody an instruction set, I can only affect their strain magnitude so much, right? I mean, if they're running, for example, you're going to have some number of body weights, right? That's not something you can really change a whole lot, but you can manipulate strain rate through landing biomechanics, through footwear, through surfaces, through a number of other things.
Great, thanks. I'm done, but maybe we can ask our moderator to add a few words himself.
Yeah, I was going to say, please respond. I want to know your thoughts too.
I'll just say that I don't think Art would have been content unless you did say that, no, Brent was wrong. All I can say is, yeah.
The other possibility is that Brent was not well trained.
Well, so what Brent left out when I filled out his nice little form, and it said, like, what are your scientific accomplishments that make you most proud? I will say, actually, the thing that I am actually most proud of, and this is not just specific to Brent, but I'm really proud of all of like what my students that I have mentored have gone on to do afterwards. That is actually the thing I'm more proud of than clinical impact. So I think, to me, that's a job well done.
Aw, all right. Thank
but
you.
he didn't want to say that because it's embarrassing. So,
in the interest of time, I don't think we get into it. Although maybe Benno brings up loading rate. Benno, do you have a question?
But not loading rate. I'm older than your mother, and I have to ask myself the question what I should do. And I always thought it's a combination of bone and muscle, and that the combination of the muscle is much more important than the combination of the bone, because you can distribute the load in the bone with your muscles dramatically. So I personally think that if I would have to give advice to your mother or to myself, is to do strength training.
So I agree with you, and I give her that advice as well. But then you have to ask yourself, why is the strength training helpful, right? And I think there's two reasons. There's three reasons. The first is that I think it contributes to mobility and fall avoidance, which is really important. The second, and general physical function. The second is that muscles load bones. So now we're back to the bone again. And the third has to do with the biological crosstalk between the muscles and the bone, right? So muscle and bone sit right next to each other. They have lots to say. And I'm fairly certain that when you are improving your muscle or losing your muscle, they often change together, but it's a whole lot faster to change muscle than it is to change bone. And I think it's also a little bit more reversible if you lose muscle. But actually, I'm gonna put my foot in my mouth now, because I actually don't know that. My sense is that it's more reversible to fix a loss of muscle than it is to fix a loss of bone.
Thank you.
Rob?
Karen, I enjoyed your talk, and thank you for the volume of material you gave us. I'm thinking that in osteoporosis, you get ribs and wrists also affected, and therefore, how do you pound your ribs and wrists like you can pound your leg bones? And so I've got two questions. One is, do different bones respond differently? in their response to any sort of activity, and has anybody looked at that? And the second one that I commonly bring up here is the autonomic nervous system has some regulatory capacity over osteoblasts and osteoclasts. And so I could hypothesize that if you stimulate bones in your legs, maybe the autonomic nervous system carries that on. Because we know if you exercise muscles on the right side, you can get a benefit on the left side. And so two questions. One, do different bones respond differently? And two, have you considered the autonomic nervous system? Because you did specifically look at local strain conditions or not.
Yeah. So answer your first question is almost certainly, and I think there's plenty of evidence for that. For example, even if you look at individuals, if you look at spinal cord injury as an example, we know that bone loss very specifically occurs below the lesion site, which is where people tend to weight bear, right? So they don't really lose bone density in their spine. They don't lose it in their forearms. They're losing it where they had typically experienced the loading and now it's gone. So I'm not a quadruped. I don't typically load my forearms as much as I load my lower limbs. And yet I'm assuming that they're somewhat in equilibrium. And then, so the third argument, right, we don't get osteoporosis in our skulls. So clearly there's a local sensitivity within different locations anatomically. In terms of why that happens, you bring up nervous system, and I think that's a key factor. I've definitely seen some evidence that if you give like an animal a botulism toxin, for example, or somehow cut their sciatic nerve, then you find that there's actually an impaired adaptation response. So that definitely seems to be a part of it. The other part, though, that I would add in would be circulating hormones. Parathyroid hormone is a really big example of that, where that's a systemic, there's definitely systemic factors that go along with it, in addition to the local factors.
Right. So have you actually, when you've had patients, have you sort of exercised some bones, but actually analyzed an unexercised bone to see a change?
Yeah, so in the forearm loading study, we exercised the non-dominant, and then we actually looked at both of them.
Yeah.
And we did not see, we really did see changes that were primarily located in the non-dominant arm. But again, there's a differential in terms of what the habitual activity is, right? So I use my dominant hand for certain things. I use my non-dominant hand for certain things. I'm not actually convinced that one is loaded more than the other by a lot, although generally, if you look at the bone size, right, the dominant form will be, maybe 4% larger than the non-dominant side.
Yeah. Oh, thank you, Karen.
Okay.
We're going to go Walter, Steve, Sarah, and then Michael. And I want everyone to get in their questions. So maybe just one question each.
Okay, thanks for, just one question.
Sorry.
Thanks, Karen. That was great. I enjoyed that a lot. Yeah, so I'm going to ask a very simple question. You showed at one point very early on predicted strains versus measured strains, and you have this very high R-squared value, 0.88 or so. But at the same time, your slope was 0.8, and you had a negative offset, which means you systematically underestimate the one value relative to the other. And do you have an explanation for that? Why you have that systematic underestimation of whatever is on the y-axis? I forgot if it was the predicted one.
Yeah, so I can tell you in that particular graph that even though it was not a zero intercept or a zero slope, those values were actually not significantly different than 0 for the intercept and 1 for the slope. But that does happen sometimes, and it's usually got to do with how you define the modulus. Sometimes you can't get it quite right, and so I think it's an important point. Is you have to decide, is your model going to be absolutely accurate versus ground truth, or are you going to be looking at a relative comparison like within subjects change? I think if you're looking between populations, or if you want an absolute number, it's really important to make sure that you have your model calibrated so that the error on average is 0. But if you're looking at a change over time, then it becomes less critical because it's a systematic error that's not going to change.
If I had a second question, which I don't, I would have asked you, what do you suggest to yourself rather than your mother and your daughter? But don't answer that.
I may, if we, you know, I could probably stay an extra 5 minutes and we'll talk about that.
Steve?
Karen, great talk. And I love the ideas of things like, I wrote it down, the bone loadometer and bone gainers and stuff, the terminology like that. Actually, I just want to ask about the bone gainers. Do you have any hypothesis of how you could identify who the bone gainers are? And the reason I ask that is in the studies that we've been doing, looking at unloading in microgravity with astronauts, we found that people who have high bone turnover seem to be more susceptible to bone loss than those with lower rates of formation resorption markers. So I'm wondering if maybe that plays a role in it, or maybe you have some other ideas.
Yeah, it's a great question. So this is to me one of the most fascinating sort of rabbit holes I can go down. I think there's probably two things going on. One is baseline physiology, right? And you're kind of getting at it with your bone turnover markers. I think again, I'm gonna implicate parathyroid hormone and sort of general response. I'm sure there's genetics in there. The analogy I use is I know there are muscle gainers, right? Like if no matter what I do, this is what I look like. I will never be a big bulky person, right? I can go and look at all the strength training I want. I can eat a lot of protein. I'm still going to be who I am. But other people seem to gain bone really fast and seem to gain muscle really fast. And I think so. So I think for whatever reason, there's something about it that's sort of tipping them in that direction. So I think part of it's physiology, and I think the other part of it is probably biomechanics, right? And so I do think that we know that people, when they go and do an activity, we do make adjustments about how we do an activity. And as a result of those adjustments to our motor control system, as an adjustment of strength, right, we're gonna apply bigger, faster, larger, maybe more osteogenic loads to our muscle or to our bone. Sorry, and then I think that muscle bone crosstalk is also playing into it some biologically. Yeah. In terms of how you figure that out, my idea would be to be looking at sort of acute physiologic response, like in some of those bone turnover markers, in some of the other circulating hormones that we know are related, really after you give somebody a stimulus. I think you might be able to find it that way.
Like
but I don't know.
A stress test or something. Yeah.
Yeah. Some kind of like a bone stress test.
Thanks. Cool.
Yeah.
Sarah.
Okay, somehow I got bumped ahead of Mike, and Mike, that was not me, so sorry. Karen, thanks for that. It was fantastic. And I was slow getting my hand up because there's too many things going through my head and listening to everyone else's questions. But I have all kinds of questions about the technical details of the bone resorption, bone formation markers that probably can be saved for another day. Our experience is there's a lot of noise, and I always worry that we're sort of over interpreting what's happening. But even with that in mind, I think the exercise studies, I always find them disappointing because you really want to see an effect in everybody, and you end up having to sort of tease apart these groups. And again, it's a bit of a noisy thing. And so much like Steve's question, but not so much about bone gainer specifically, how would you roll out an intervention? Again, thinking of your mom example or your daughter example that you think is actually going to benefit a large group of people. I know your loading model is probably great for, falling on your arm, maybe.
Yeah, nobody wants to do it though.
Right. So I'd just be curious your thoughts on that, apart from like the basic mechanisms of how this might actually happen. But
yeah, I mean, I think there's, in terms of figuring out so I guess how the practical part of how you would roll out an intervention, I think kind of gets into the exercise psychology almost. And I think it involves feedback and it involves motivation and all sorts of other things. But
Sorry, I'm more thinking about the actual, like, what intervention would you do?
Right.
Recognize there's a whole other, like, how do you get people?
Yeah,
to
no,
it?
I mean, I
You know,
think so. So I think there
Yeah.
are. So I mean, we know what works, right? I mean, there have been clinical trials done. They're hugely labor intensive, but they generally show that things like, you know, hopping and jumping and plyometrics and, you know, strength training, like those things work, right? But the question is, how much do you need, and how do you, you know, how do you decide if you've gotten there or not? And so I think that's actually where some individual calibration could really be helpful. So for example, maybe it's a Warren sensor type of a thing, and going back to my bone loader beater, right? You know, maybe we figure out that, you know, you just need to have X number of loading cycles at X strain, right? So you have to have some sort of a surrogate method for strain that you can, you know, have on an individual basis, right? It can't be force, because my bone is bigger than your bone. So the same force on my bone is going to cause lower strain than your bone. But if strain is a signal that we care about, we have to figure out some way that to measure it and quantify the dose. So I'm still not quite there yet, but I do know what we need to tell people to do. It's a question of how much do they need to do to get the minimum benefit, right? So I can kind of go back and say, okay, well, you know, there's been some very clever animal studies where they said how many jumps does it take, you know, a mouse to maintain bone mass, right? It's like 6 jumps a day or something, right? That's all they got to do is, you know, drop them off a, you know, maybe that's all we got to do. We just got to jump off a box 6 times a day, right? So I haven't calculated what that minimum dose is, but we're playing with that at this point, and I don't quite have the answer.
All right, Michael.
Cool. No worries, Sarah, about taking my spot. I get to pretend I'm Walter today. So thanks for the nice chat, Karen. It was filled with lots of interesting stuff and many words that I've heard come out of Brent's mouth before. So that's great. So my main question is, I want to know what what you think is the interaction between bone microstructure and macrostructure, and which one is more important when it comes to reducing fracture risk.
Good question. I think that, so interaction, I mean, obviously they're connected, right, mechanically. I think it depends on whether you're talking about fracture. So at the end of a bone, there's a load transfer that happens, right, between the trabecular compartment down into the cortical compartment. That transfer is really important. And if you don't have the trabecular structure to transfer the load, it doesn't make it, right? You're going to get a vertebral crush fracture or whatever. At the same time, depending on the fracture mechanism, like if I go back to my tibia, right? So if I twist a tibia, the biggest stresses, the biggest strains, the biggest shears happen at the surface, right? That's all cortical. And so depending on how you're loading the bone, it may be more important to have a strong cortical structure or a strong trabecular structure. So I guess I can't give you a definitive answer that is satisfying, other than to say I think they're both really important. But at the end of the day, if I had to pick one, I'd probably say cortical bone is more important than trabecular for most fracture scenarios. But I think trabecular bone is more metabolically active because there's more surface area. So, you know, it's easier to make a change.
Excellent, thank you. I'll let you go. I have many thoughts on that. So thanks for the nice talk.
All right, thanks.
Walter, do you have any last minute pressing questions?
Oh, no, we know that Karen needs to go. So that's great. Fabulous. Thank you.
Well, thanks a lot, Karen. It was a really great talk and a great summary of a really nice body of work. And so we don't want to keep you any longer. So we'll let you go. Next week, I believe, I could be wrong, but I believe we're going to be listening to Matt Jordan, but I do not have a tentative talk for his seminar. So thanks everyone for coming. And we'll, thank you, Karen, and we'll see you all next week.